She's very nice.
She's very nice, yeah.
Yeah.
Michelle, you
Bad
have
for
any
her.
questions for us?
I don't think so. Just let me know if you need anything else.
Sure, thank you for your help.
Sure.
Thank you. All right. So, Heather, so what did you hear when we were examining her chest?
The team reassembles in the corridor, and after checking to see if the nurse has any additional input, the team begins discussing the physical findings with a question to the medical student.
So why do you hear crackles and
Because
pneumonia?
it's wet, right?
Yeah, junk. Yeah.
So whenever you have any air and fluid in your lungs, that will produce you to have crack.
Note that the teaching is not restricted to the senior resident. Here the junior resident is engaged in teaching as well.
Crackles and pulmonary edema because of the fluid in your lungs.
Right. So when would you hear increased tactile fremitus and megaphony and pectoraloquy and all those things that are typically described with pneumonia?
With an effusion?
Not with an effusion. Chico, what do you
In consolidation, because the fluid is a better conductor, so you'll hear it louder.
Exactly. Now we look at the X-ray here, and you don't really see any fluid. Right?
The team now turns to the patient's x-ray for some additional teaching.
So the infiltrate is here on the right side, and you can see the costophrenic
Yeah,
angle.
the margin is sharp.
Very well demarcated. So then that sort of indicates that there's no fluid. If you really wanted to make sure there's no fluid, you should probably get a lateral film, which she doesn't have, right? Because fluid goes, right?
You have a meniscus effect.
Not all the questions are directed at the medical student. Here the junior resident gets the question.
Your costophrenic space, because phrenic angle is posterior. So you see it on the posterior angle of the costophrenic space, sort of. So that's where you would look for fluid. So and you see, as you were saying, that meniscus line, which is sort of an upper concave density.
So we got it early.
Exactly. Well, yeah, it seems like.
Although the medical student is the most junior member of the team, she has been made comfortable enough to ask her own questions.
Well, I think the guidelines say that whenever they're able to take PO, you can switch it because IV is not really better than PO antibiotics.
Right.
But she's not really eating that much, so I guess we can give her another day and maybe tomorrow.
Now the team turns to discussion of the treatment plan for this patient.
She was pretty sick on admission. She was
Right.
only 90%. All right. Good. Any questions? Anything else?
So, Ricardo, what about her disposition? Do we keep her in step down for today or do we move her to the floors?
Finally, the team discusses the patient's disposition, in which part of the hospital she should be kept. Again, there are hospital-specific terms like step down and GMF, which you will have to learn.